Bismillahirrahmanirrahim. Welcome to Al-Ainy Postgraduate Orthopedic Review course. And Ashraf Moharram. I will be giving you an idea about fractures of the scapula. This is my neighbor. He's 35 years old. He had a motor car accident and suffered this isolated injury. How will we treat him? Operative, conservative? How will you choose his treatment? I hope by the end of this lecture, I'll help you evaluate scapular fractures, classify them, and identify the indications of surgical management, as well as the operative approaches, and know about the outcome of management of these cases. It's rarely broken, the scapula. It's less than 1% of all broken bones. وده متوقع بصراحة. It's thin, elastic, freely mobile, covered with a lot of muscles, and it lies on the thoracic cage, which has a lot of malleability as well. It represents 3 to 5% of all fractures of the shoulder girdle, and it is usually part of a high energy trauma. 90% of these patients have associated injuries. The mechanism of injury is usually a direct blow, although indirect blows can happen usually through falling on outstretched hand and the humeral head hits the glenoid to fracture it or cause a fracture dislocation of the shoulder joint. However, direct trauma with high energy is the most common mechanism of injury and is associated with other injuries in 70 to 100% of patients, depending on which studies. What are the common associations? Well, rib fractures and skull fractures are the most common, followed by spine injuries, which are about 16% as well. Cerebral hematomas, contusions, neurological injuries, hemopneumothorax, pulmonary contusions, and subdural injuries are also common in these patients. So clinical examination includes suspicion, then inspection, cervical spine and thoracic spine examination, thoracic auscultation evaluation, neurological and vascular evaluation, as well as looking for associated injuries we mentioned. What is the radiological examination? Standard is an AP and lateral scapular view, called the Y view. This is both are in 45 degrees parallel and perpendicular to the axis of the thorax, which is 45 degrees already to the scapula. We rarely can use the axillary notch view because it is quite difficult to achieve this amount of abduction in fractured patients. CT scans with 3D reconstructions are standard procedures that help evaluate the situation. Chest X-rays are a must as well. You have to look at the lung. The costophrenic angle has to be empty, and look for pulmonary contusions or hemopneumothorax in a chest X-ray. So traditionally, these fractures are treated non-operatively, and over 90% of scapular fractures are non or minimally spaced and do well with conservative treatment, and the results are usually quite impressive. However, more and more studies document the residual symptoms as well as advantage of operative treatment in many injuries. As about 30 years ago, Nordvist has published a paper about 48 patients, 20% of which developed a malunion of the scapula, and most of which had residual symptoms in the form of pain, this functional deficit, decreased range of motion, and shoulder imbalance. So malunited fractures of the scapula results in ulnar shoulder girdle dysfunction, malaligned dysfunction of the rotator cuff, impingement type of pain, scapulothoracic and scapulothoracic dyskinesia, which would affect shoulder function. So more and more operative treatment results are becoming published, and people are considering them safe and effective. So in 2013, the AO Foundation and the Orthopedic Trauma Association of America formulated a joint commission, which was headed by my dear friends Martin Yeager and Simon Lambert, to come up with a scapular fracture classification system that's both comprehensive, reliable, and easy to use. They have divided the scapula into 4 bits: the fossa, F, which is the articular segment, the body B, which represents the main part of the scapula, minus the processes, which is the acromion and the coracoid process, while the S stands for the lateral scapular suspension system, FBPS. There are two levels of classification: the basic system for rapid simplified documentation, which is commonly used, and a level 2 system, which is more detailed and documented mainly for scientific purposes. The fossa body, the fossa, which is the glenoid surface, is divided into F0, which the articular segment has no fracture across it, which is basically a neck fracture, while an F1 is a simple pattern running across the glenoid, while F2 is more than one fracture line crossing through the glenoid. This, as regards to the body, it might be a simple fracture with one fracture line and 2 exits, or more than 3 exits involving the body. And it's subclassified if with or without glenoid involvement. What about P? P stands for a fracture of the coracoid. P0 is a fracture of the coracoid. P1 is a fracture of the acromion, while P2 is a fracture involving both the acromion and the coracoid. The lateral scapular suspension system is symbolized by S. In S0, there's no involvement of the system, while in S1 there's an incomplete failure, which means one break, which might be a fracture of the clavicle lateral to the coracoclavicular ligaments, or an AC joint incomplete separation, or a fracture of the base of the coracoid, or a fracture of the spine, or acromion of the scapula. While S2 is a complete failure of the lateral suspension, scapular suspension system, usually involves either a fracture medial to the coracoclavicular ligament, or a complete AC disruption with a rupture of the coracoclavicular coracoclavicular ligaments, or a fracture of the base of the coracoid with a fracture of the spine or that of the acromion. Treatment. Surgical treatment recognizes 3 major points we have to take into consideration. One is known as the glenopolar angle, which represents the rotation of the glenoid, while the angulation of the body is also something to be considered, and the amount of medial and lateral displacement. These 3 elements affect the movement of the shoulder dyskinesia, and the function of the muscles around the shoulder, especially the rotator cuff. In a systematic review, it was found that the most common causes of surgical intervention was glenoid fossa fracture, neck fractures, or ipsilateral clavicular fractures. Ipsilateral clavicular fractures may or may not be associated with a floating shoulder. A floating shoulder is when we have a fracture through the glenoid neck and is associated with either a medial fracture of the scapula medial to the coracoclavicular ligaments, or a rupture of the coracoclavicular ligament with a fracture of the distal end of lateral clavicle, or a complete AC disruption, or an acromion fracture. If this happens, we have got a floating shoulder. And the question that has been asked for many years, does fixing the clavicle in this patient with a displaced neck scapula and a clavicle fracture, does this reduce the scapular neck? Well, it might be, but usually not. If you have the situation, usually go attack the clavicle first, and then flip the patient into a prone or lateral decubitus, and then attack the glenoid as well. Okay. Intra-articular fractures of the glenoid represent 10% of the scapular fractures. 90% of those are undisplaced, while the 10% are displaced and require surgical treatment. Iberg classification describes 5 types of glenoid fractures. If there's an articular step-up of more than 2 to 5 millimeters or shoulder instability, this fracture should be fixed. While glenoid neck fractures are most commonly managed conservatively unless there are medialization of the glenoid or rotation of the glenoid through the glenoporal angle. Medialization of the glenoid leads to the scoping, shortening, and disruption and dysfunction of the rotator cuff. This displacement was measured by the lateral border offset, and if it is more than 10 to 20 millimeters, we consider this as disruptive to the rotator cuff function and shoulder function. While the glenopolar angle represents the line between the most cranial point of the glenoid and the tip of the scapula and the angle of the glenoid, it's usually between 30 and 45 degrees. If it's less than 20 degrees, usually results are not that good, while good and excellent results are usually less than 18 in angles more than 20 degrees. So many studies have correlated poor outcome with glenopolar angle less than 20 degrees. Restoration of the glenopolar angle is important goal for the surgical management of fractures of the body of the scapula. While about extra-articular angulation, more than 30 to 45 degrees can result in dysfunction of the shoulder muscles and scapular dyskinesia. So how do you treat that? Either ventral approach, deltopectoral approach, not commonly used except in fractures of the anterior rim of the glenoid, the coracoid fracture, or acromion fractures, while posterior approach is most commonly used for glenoid neck and corpus fractures. In another systematic, in the same systematic review, we found that 80% almost are managed through a posterior approach. Posterior approach are two types, either classical Judet approach or a Brodsky approach. This number one incision here represents the classical Judet approach, while the Brodsky approach is presented by the line entitled number 2. In the Judet view, we get to expose the body, the neck, and the glenoid itself. We go parallel to the acromion, detach part of the deltoid, although this is now not recommended at all. And we elevate the infraspinatus off the body of the glenoid. We leave the infraspinatus to hang on the suprascapular nerve and vessels. You can see them here. This is the glenoid notch, and this is the infraspinatus, and this is the neck of the glenoid itself. So part of the deltoid here is elevated. You've got the infraspinatus. You pick up the space between the infraspinatus and the teres minor. It's usually difficult to pick up this medially, but the more you go in a lateral direction, you'll be able to identify them. And one of the good tricks is to lower the diathermy to 1, and if you touch the infraspinatus, it will contract independently of the teres minor, and you can see clearly the plane between the two muscles. Now, this plane is developed between the infraspinatus and the teres minor, and we can expose the posterior capsule, the body, the neck, and through the same plane. And this is again the suprascapular nerve and vessels going into the glenoid, into the infraspinatus, I mean, and you can do a capsulotomy to see inside the shoulder joint and identify the glenoid itself. What about the Brodsky approach? The Brodsky approach utilizes 3 windows. It does not involve inserting the glenoid or flipping the infraspinatus off the body of the scapula. The main window is again that between the infraspinatus and the teres minor, and the other 2 windows is between the teres minor and teres major, and between the teres major and the subscapularis. It's a straight incision develop the plane, and you can get to look as it can give you most of what you can see, what most of what you could see from the Glossary approach, what you can see in the Judea approach. Where to put your plate or your internal fixation? You need thick, strong bone. So you should look for the bone around the glenoid neck, the spine of the scapula, you can see that in transillumination, or the borders of the scapula, especially the lateral border and less commonly the medial border as well. So you remember my next door neighbor? This is his x-ray. How will you treat this guy? Look at his glenopolar angle. Look at his amount of medialization. You know, we say 10 to 20 millimeters of medialization. Well, if it's only medialization, you can take 20 degrees. But if it's also loss of the glenopolar angle, we say 20 degrees of glenopolar angle. So if there's 10 millimeters of medialization and say a glenopolar angle of less than 20, this is an indication of surgery. And that's our situation here. We thought he was indicated for surgery. We put him in a prone position, use lateral as well, open this classical Judea approach, detach the infraspinatus and dissected the teres minor and put two plates, one on the lateral border and one on the spine of the scapula and the medial border. Most of these patients do quite well post-operatively. We know that good to excellent results in surgical management of scapular fractures when indicated is close to 84%. What are the post-operative complications? 4% infection rate in this systematic review, and problematic or prominent hardware in 7% that required removal, and joint stiffness, residual pain that required medication and anesthesia in 4% of the patients. So my take-home message to you is be aware of high incidence of associated injuries. This is very important. This can be life-threatening. Conservative treatment is the mainstay. However, operative when indicated yields excellent results with a low complication rate, articular step-off 2 to 5 millimeters, or shoulder instability, medial displacement 10 to 20 millimeters, a glenopolar angle of less than 20 degrees, and a floating shorter should be indications for operative management. Stabilization with plate and screws is the standard procedure through a posterior approach in most cases and with acceptable results. Thank you so much. It's been a pleasure, and I hope this is useful.